Hello, welcome to Maternity Nursing 2. I'm Miss Kinan, and today I'm going to present the material created by Miss Eva Berti, PhD, and the titles of today's presentation is Nursing Care Plan for a Woman with Reproductive Disorder to learn about pre and post hysterectomy, as well as pre and post salpingectomy. So the objectives of our class today that you will be able to correctly explain for types of hysterectomy, correctly explain two types of salpingectomy, and then you will understand also the terms TAHBSO, which is total abdominal hysterectomy with bilateral salpingo-oophorectomy. And you will understand also how to take care or how to perform nursing care plan to women undergoing hysterectomy and salpingectomy. Let's get started. So, as international nursing student, you have to learn this book. This is from our Loader-Make book. It's available online from our portal. So please have a look and take a read and chapter 11 from our book. It will talk about a lot of structural disorders and neoplasm of the reproductive system that is happening in women. So let's begin. We are going to talk about the problems in reproductive system or something that we call gynecology. Especially what we learned today is about hysterectomy and salpingectomy. So what is gynecology? Gynecology is the study of disease that related to the female genital tract and reproductive system, which also related to their obstetric conditions. For example, if they're pregnant, if they have given birth, or even the postpartum period of the woman. So, hysterectomy and salpingectomy is one of many problems that we have in obstetric and gynecological condition, which then start to become complications in the pregnancy less than 20 weeks, which is happen such as ectopic pregnancy or even endometriosis or even uterine bleeding. And if you can see here, we have the normal reproductive system of a female. So you can see the rectum, you can see this is the uterus and this is the bladder. So this area are the things that having problem in gynecology. So we probably have the women that have problem within their uterus or even the bladder. They cannot control the bladder because it's incontinentia, and they also have problem with their rectum so that they cannot poop very easily. Well, what is hysterectomy? So we're going to see the definition. It's a surgical procedures or a treatment technique for conditions such as fibroids and endometriosis, which accompanied by chronic pain, and as well as uterine prolapse or even happening in gynecological cancer. So we want to learn about what it is so then we as nurses we will be able to take care of our patient who are going through this certain medical procedure. A total hysterectomy means that there are the removal of the entire uterus, which is this is the treatment of choice if the bleeding is very severe or if the fibroid is obstruction, it's causing obstruction on the normal functions on the other organs of the mother or the woman. Now take a look at this picture. So we have what we call vaginal hysterectomy. So what they do is they remove the uterus through the vagina. So it calls vaginal hysterectomy. And what we have also another one that very common that we will always see in our journey as nurse is abdominal hysterectomy. So in abdominal hysterectomy, what happened is they do a cut on the abdomen, and then they cut also the uterus, and they took the uterus through the cavity on the abdominal wall. So this is what we call abdominal hysterectomy, and this is very common. And as nurses, we are going to take care of the patients with abdominal hysterectomy, so we need to learn about this materials. Well, now take a look on the types of hysterectomy. There are four types of hysterectomy. The first one is here. You can see that this is our uterus, and this is the cervix. We have the fallopian tube, and we have the ovary. So this is the normal structure of a woman's reproductive system. And then we will see what we call total hysterectomy. We also will have what we call supracervical hysterectomy. So it's just above the cervix. And then we have what we call total hysterectomy with bilateral salpingo-oophorectomy. So what happened is that we remove all the ovaries, we remove the fallopian tube, as well as we remove the uterus. So this is what we call total hysterectomy with bilateral, so both of it. And sometimes we also have what we call radical hysterectomy with bilateral salpingo-oophorectomy. So we just remove every single thing and we just leave the vagina. Now, let's begin. So, as I mentioned before, the total hysterectomy means that you can just remove the uterus and then leave the cervix. The uterus and the cervix sometimes, and then you leave the fallopian tube as well as the ovaries. In the patient who have this treatment, the woman will not experience menopause because why? The ovary is still there, so she still has the phases of having the hormones that will not make her having the menopause stage. Next one is what we call supracervical hysterectomy. So it is this one. So the supracervical hysterectomy is that we remove only the upper part of the uterus, right? This one, and then the tubes, and also ovaries. So we remove everything, but then we leave the cervix. So, well, in the journey of as the women live by and as she continue her routine and everything, the woman still needs to do a pap smear to check whether she will be able to get cervical cancer or not. Another one is what we call total hysterectomy with bilateral oophorectomy, or what we usually have the abbreviations for THBSO. So this is the removal of uterus, cervix, and fallopian tubes, and the ovaries, or oophorectomy. Oophorectomy. So here, this one, we remove this both of it. And when we remove all the parts of the specific important part of women's reproductive system, obviously the women will go through menopause. So it's very important for us to be able to know, so we will then be able to explain to our patients what to expect during their healing period. And then we have what we call radical hysterectomy with bilateral salpingo-oophorectomy. So what happened? We remove all the parts contained, such as uterus, for short, the cervix, the tubes, the fallopian tubes, and as well as the ovary. And sometimes we also remove an upper part of the vagina. So when also the cancer has spread to some tissues nearby and also some lymph nodes, then we also remove that one. And this type is actually the most common used by the doctor when there is cancer. So once we see that the myoma has turned into cancer, then we have to remove everything. And for sure, the woman, as the ovaries goes, then the woman will undergo a menopause. So very early menopause will be experienced by our patient who undergone the radical hysterectomy with bilateral salpingo-oophorectomy. So this is very important to note and very important to let them understand what will happen in their life continuing on. Now, let's talk about what we can do. So, as nurses, we will be able to be with the patient during the treatment or the procedure. So, what we do, we help them in preoperative care during operation as well as postoperative. So, in the preoperative stage, what we have to do is we make sure that the doctor and everyone who take part in the surgery have explained about the procedures as well as we ask for informed consent. So in this time we ask for all the preparations such as the blood samples, urine samples, how to do the recovery process, and even talk about the plan for home care after the surgery. Now after that we are coming to do the operation. Before the operation also, the doctor must have explained about what will be put on the patient, what will wear, and how the surgery will happen, and how far it can go wrong, and how far that they try to make it go right. Anyway, now we move to operation. During this operation, we then, the ward nurses, will deliver our patient to the surgery room, and then we will do the handover, and then the patient will be changed to the operating clothes, as well as there will be monitor that will be attached to the patient chest so that we can do the cardiac observation. Sometimes we do insert an IV, but sometimes also this happen within the ward, so we already prepare the patient with the IV, and then we administer also anesthesia if it's needed. Now, postoperatively, we focus on the issues such as pen, wound, medication use, as well as, for example, if the woman needs an S8, so we ask them to use the non-steroidal anti-inflammatory drugs, or sometimes also acetaminophen. And if your patient has allergy of this type of drugs, then we have to figure out on what type of pain medication that can be used for the pain management in this patient. Well, we talk about home care as well, where we see where is the wound, how can she then be prepared to do life. So we do this as well before we start the treatment to the patient. Next one. How to take care of the patient with hysterectomy. So I will share with you, this is some methods that has been written in your book. So if you read your book, you have seen this one. So there are what we prepare for our patient before the operation. So we have the vaginal examination, physical examination, we do the lab tests, we do all the blood, complete blood count, the type and cross match if we need to do blood transfusions within the operation as well as after the operation or before the operation, and we do the urinalysis. We make sure that the chests are okay. Cardiologists will check if they have problems. We do ECG. Then we teach the postpartum, the postoperative routines that probably will be happening after the surgery itself. So, for example, we teach them how to turn, how to do coughing, how to do deep breathing, how to do the passive and active leg exercises, as well as if we know that the patient have the needs for early ambulation. So we ask them to mobilize very early so that we then prevent all the bad things that might occur. And also, we explore together with them what is the pain relief available for their pain condition after the surgery. So remember that before the operation, before the surgery, they will ask the patients to fast, so nothing by mouth, nil per mouth, NPO, before the surgery is ordered, and probably they also ask the enema, probably also they need the douche. Remember I talked about the douche, you have to clean the vagina, and enema, you have to clean the rectum, so there's nothing there. And then probably because this is an operation that happened in your abdominal region, you probably also need to do some hair clipping or some shaving of the hair on the pubic area, so it will be easier in the decontaminations after before the surgery started. We also have to make sure that our patient remove their makeups, remove the nail polish, remove the glasses. Or if they want to bring the glasses, she can still have it and by your side. And for sure, there's no contact lenses as well as dentures. Why not dentures? Because we try to probably will need to intubate the patients, and it's very dangerous that it can go through your airway. And we put the ID band of the patient's place in hand, as well as they have to sign the informed consent on the chart. And before we go down to the OT, we ask them to empty their bladder for the surgery. Another thing, we learn about what to do after the surgery, after hysterectomy. So obviously we monitor the vital signs every 15 minutes until it's stable, and every 4 hours for the next 48 hours, or more frequently as ordered, as well as remind the client or patients to turn, to have cough, to hold the strength to the pillow, to do the deep breathing every 2 hours for the next 24 hours. And we also help them to do the splint with the hands or the pillow. Now, if the surgery get longer, than what was expected, then probably we have to do what we call an incentive spirometry to just see how far is it the anesthesia have then given a problem or have changes the normal routine of the patient. Then we ask them to do like exercise every 2 to 4 hours. So we can use what we call the SCD, so it's the sequential compression devices, or you can also just simply use the DVT socks to then help the patients to not build up DVT or deep vein thrombosis. So we also ask them to do ambulatory. So we do the range of movement, active and passive, through the very first time after the surgery. Now, we then also monitor the bleeding because she just undergo the surgery. So we see how is the bleeding, we see the abdominal, we see if the dressing is good, we see if there is leaking on the dressing, and then we check also on her vagina whether there is anything that coming out. It could be vaginal bleeding, it could be other thing, but we just monitor it, we just see and assess for any possibly bleeding that may occur in your patient after surgery. And then we also monitor the lab values. So mostly we will do the CBC, the complete blood count, so we will know what's the hemoglobin and the hematocrit as well as the leukocytes, so it's just the main. And then we also assess the lung sounds. We also assess the bowel movement and the bowel function, because then after the anesthesia sometimes it's getting slower because it's just the effect of anesthesia. And then we also monitor the intake and the output. So normally we will have our patient with Foley catheter in. So after the surgery they'll come back to the room with the Foley catheter, which we will be placing them within 24 hours. So what happened, we have to monitor that one, because after surgery, either they do abdominal hysterectomy or vaginal hysterectomy, we have to see how their output is. And if it is like a vaginal hysterectomy, what will happen that the urinary retention may occur because we have to do some manipulations by the urethra and then it's changing, so that make our patient will need to adjust again after the surgery. And if our patient complain of not being able to pee after 4 hours or within the 4 hour, we have to really notify the healthcare provider so we can see what we can help to make her feel better. And then we also assess the abdominal incision, or if then we see any signs of infection through the surgical side or even through the vagina, because I don't know, probably something happened during the surgery and it caused infection. Then we also observe for signs of complication. This can be for example, well, we mentioned about bleeding, we mentioned about urinary tract infections as well, or probably just urinary retention. And then we talk about the pain relief. So we help the patient with the pain relief. So we do the pharmacologic measurement to the patient. We give them PCA or patient-controlled analgesia, or we do the epidural opioids to the patient, which then be ordered for the next 24 hours. And then after that, probably we will switch to oral analgesia. Then we also can use what we call the NS8. So then we make sure that the pain is controllable, the patients will be able to tolerate the pain, and then she then can move on to then be discharged from the hospital. So we also teach how to do pain relief non-pharmacologically, like for example breathing techniques, relaxation techniques, position changes, even with listening to music, guided imagery, or even try to put like patch, hot or cold patch, which one will make her feel more better, as well as we also assess the psychological side. So we assess if there are needs of support system, whether the patients fall into depression after this, or is there any concern that then will change her state of being. Now we move to the next condition, which is salpingectomy. So the salpingectomy is actually the surgical procedure to remove one or both, so unilateral or bilateral, the fallopian tubes. It's the tubes that connect the ovaries to uterus, and when we remove it, this will be also a sign of the permanent sterilization. So it's commonly performed to treat ectopic pregnancy. So the pregnancy happened not inside the uterus, and when we have severe infections that cause problem on the cervix. So as you see here, this is total hysterectomy. This is radical hysterectomy, and when we call it salpingectomy, probably we did not do hysterectomy. So the uterus is still there, but we removed the tube, the fallopian tubes, as well as the ovaries. So that's gone, right? And then the positions can be low transverse incision, or sometimes can be also vertical incision. Now, there are two types that commonly done for a salpingectomy. The first one, as you see here, so this is, you can see the fallopian tube, this is the ovaries, this is uterus. They will do with this scope. So this is what we call laryngoscopy. So we did not do a big incision, but we only do very little incision to let the to let the laparoscopic scope inside, and then we cut it and then get it out. So that's how we do it. We do with the laparoscopic one. So this surgery with laparoscope is a thin instrument with a light and camera on the tip. So the incision will then be done by the laparoscope. Then we will inflate it. So the operator, the surgeon, the OBGY will then inflate the cavity uterus, the cavity, to then be able to see the uterus, and then we'll be able to see and then just then remove the fallopian tubes on both sides if it's bilateral, and on one side if it's unilateral. Then we then just drain the excess blood and fluid and then close the incision using stitches. So the wound that will happen after this laparoscopic salpingectomy is actually a small wounds, but there are like 3 holes, so we have 3 small wounds on the abdominal. The next one is what we commonly use is open abdominal salpingectomy. So we just do a single large incision on the abdomen and then remove the fallopian tubes through this incision. And sometimes after we'll find that there are very large wounds on the abdominal, and then there will be a lot of stitches that sometimes be done through staples. Now, the treatment for the procedures of surgery kind of similar with the one with hysterectomy. So we do pre-operatively, you explain, you do the informed consent, you prepare, you check everything, and then during the operations, you explain what will happen, you hand them over to the nurses or to the OR, and they will help with all the cardiac observation, IV injection, and then even an administering of anesthesia. And then we do post-operatively. So we manage the pain, the wound, and we use the medications that needed, as well as we plan for the home care. Now, I want you to do exercise. So I put this on the discussion forum. So please do the critical thinking questions. So I will ask you about the similarities and then the differences between hysterectomy and salpingectomy. So remember, this is a group work. So please upload it to your assignment as group. Now, we talk about the total hysterectomy with bilateral salpingoperectomy. So this is a surgical procedure to remove the entire uterus, cervix, both fallopian tubes, and both ovaries through an abdominal incision. So this procedure used to target the large fibroids and severe endometriosis as well as cancer. And then it's mostly used for large fibroids or myoma. And then it carries risks such as bleeding through surgery, probably also need blood transfusions, as well as there will be infections of the bladder or the surgical side. Then there will be also damage on the surrounding organs just because we've done the surgery. And then if there are damage, then there's possibility that we need to do further surgery. Now take a look at this. So this is what we call THBSO. So it's total hysterectomy with bilateral salpingo-operectomy. So these are the picture that you can see. As you see, there are uterine myomas here. So you have the uterine myomas by the side here, and then you can see that through the ultrasound you can see this is how it looks like, and then once they open the abdominal you can see how big the myoma is. and then you do removal of that. So that's what happened in the removal. So they myoma, and then they remove all the uterus, and as well as the sides of the selfing left and right. Now, commonly found subjective and objective data is that there is a specific consent that being said about the surgery, the outcome, the fear of rejection from the significant others after knowing. There's also withdrawal, depression. Sometimes there's also the sensations of the bladder fullness and urgency to urinate just because something happened there and it changes. So then they feel different. And then we can have the impaired urinary elimination function just because the frequent and amount. And we can also have the incontinence. So the patient won't be able to control their pee, as well as there will be the bladder distension, and also probably the patient will be questioning a lot about information, stated the misunderstanding, and as nurses will be able to explain as the best, and we ask for help from the doctors if we don't know the answer. The last one, there will be also inaccurate follow-up of instruction, which then sometimes cause the complications to our patient. Now, this is a case report. It's a 46 years old woman coming to the hospital with abdominal pain. She felt it for a week, and then it's worsened in the last 2 days. And then she said, and commonly she has pain, and she also felt like there are lumps in the stomach that getting bigger in the past 9 months, and there's no menstruation for the past 3 months, and then also no excessive vaginal discharge, but then it's very uncomfortable, and she has difficulties in defecate as well. So think about what you can do to this patient. Now take a look on this pathophysiology. So you will be able to see this. We'll be able to see how it started. So there are three types of myoma that happen, which then cause bleeding as well as enlargement. And then will happen. What will happen is that we can have the perforation disturbance, and then perfusion, disturbing perfusions, and then we also have the risk for infection. We have also anxiety to go through operations, and even we have the pain. And then afterwards we will have the problems of urine eliminations, as well as problem of eliminations or defecate. So as you can read here, there are also a lot of interventions, and as well and how it happens, and also the nursing diagnosis. Now, these are also the clinical findings. So you can have like pelvic pain, iron deficiency anemia. There will be the enlarged abdomen, urinary incontinence, is even a constipation because there are changes in the pelvic mass. Now, the priority problems in intervention care plans, the first one will be about pain management, because this is after surgery. She is not comfortable, so you manage their pain through using the pain medication. And then you do the wound care and infection prevention for sure, because there are wounds. So you do the proper wound care, you help them to see how it's the sign of infection, so they will be able to be aware, and they will come to the hospital once it happened, and then this will be very crucial so they don't have complications. As well as we also do what we call DVT thrombosis prevention, deep vein thrombosis prevention. So in here we try to help the patients to just move, so that the early embolations will do, leg exercises will help, and then sometimes if it's very severe, then we also administer anticoagulants, so then the patients will not develop thrombosis. The next one is we do also control the bladder and bowel function. So we figure out and we make sure that they will be able to defecate and urinate. We help them to do the Kegel exercises. So we ask them to consume high fiber diet, so they will be able to have the bowel movement, as well as we control the emotional well-being. We ask them how they're doing, how are they coping with this condition, and how are overall their well-being. As well as we also can think about the hormonal replacement therapy, because if we move all the organs of the woman body, then we understand that there will be hormonal imbalance. So we ask them if they need it, and we also educate them, and we talk also about this to their family and also to the healthcare provider. Now there is two case that I want you to do. You have two patients. Do this as a group assignment, upload it in your group assignment. But you need to do what will be the nursing diagnosis, pre-operative, during operation, and after surgery. And then please do a health education leaflet for these two patients that you will be able to then give intervention for their case. All right. So that's the class for today. I hope you learned something. Bye bye. God bless you.